Started. Okay. Great. Well, welcome to the second meeting of the Universal Health Plan Governance Board to everyone. Before we head into introductions, I want to do a quick technology check. Katie, I think we have new mics that you need to show us how to use. Could you do that?
Yes, absolutely. So before you speak during the meeting, you will, unless for roll call, you don't need to worry about it. It's just when you have speaking otherwise, you will push this button until the light turns green. And then that's just going to amplify your voice so that everybody in the room can hear. Can you hear it a little bit better? And then when you're done, you just push it again. And that will just ensure we all hear each other okay. So we'll kind of work, it's the first time, but we'll work that out together.
Great, thank you. And then we have a couple of board members participating virtually, Michelle, Judy, and Chunwei. Can you see and hear us okay?
Yes. Yes, I can see and hear.
Okay, great. And then board members in the room, any questions for Katie about technology or?
Thank you.
Cool, great. Well, let's get started. My name is Helen Belanca. I'm honored to serve as chair of this group. And first, we want to get in the habit of acknowledging public comment and outreach to the board. For those of you listening in who have sent us emails, thank you very much for taking the time to reach out to us. As of Monday morning, which is our 72-hour cutoff, we haven't received any official written public comment, but we have received several emails, and we want you to know that we're reading them and considering your comments. And then per our policies, we're passing them on to Morgan if she hasn't already been included on those emails. Part of this board's work moving forward is going to be developing a formal community engagement plan, which will involve quite a bit of outreach. And we're hoping to talk more about our work with interested members of the public in a more formal and organized way with that. But of course, we're always happy to receive your emails. So let's start with some introductions. Please tell us your name, and then as we head into summer, I'd love to hear about your favorite place in Oregon to vacation. Amy, you want to get us started?
Sure, Amy Fellows, and I'm gonna cheat, and we have there's a cabin in the Puget Sound near Olympia. I've got to since I was a child.
Deborah Diaz. I will be taking a road trip later this summer to see Crater Lake for the first time, but I really enjoyed going out to Eastern Oregon and the Steens Mountains, Alpha Desert. That was beautiful.
I'm Helen Belanca, and I think my heart is always in the Columbia River Gorge. It's always my favorite place to visit. Oh, sorry. Sound for you.
I'm Myron George. My favorite places in the mountains or the coast or the valleys. And actually, my wife and I are going to Alaska soon.
Bruce Goldberg, Sisters Wilderness.
Cheryl Ramirez, and like many of you, I like all parts of Oregon. It's a magical place.
Michelle?
Good morning, everyone. Michelle Glass, she, her pronouns. I also have a hard time choosing, but hiking and rock hounding in the high desert in Central Oregon is one of my summer favorites.
Judy?
I hear you, Michelle. I'm Judy Richardson. I live in the beautiful Columbia River Gorge, and it's so hard to choose, but my heart, I love going to Central Oregon and smelling the sagebrush and juniper. So.
And then Chunwei?
Yeah, it's also hard for me to choose. My name is Junhui Ji. I actually have two favorite summer places to visit in Oregon. One is Bend area. The other is Astoria area.
Excellent. Great, thank you. So a quick review of our agenda. We've got several elements of our agenda today that need board action. That's noted on the agenda under purpose. And if the board's ready, we'll approve our policies and procedures today and possibly establish a couple of work groups to help us get our work moving forward. There are several topics for discussion today. For those of you in the room, if you're You can either raise your hand, or if there are a number of people waiting to talk, we can adopt the policy of turning your name tent on its side so that I'm aware, so you don't have to hold your hand up that long. And then for folks on the virtual meeting, participating virtually, do you all know how to use the raise your hand function? Great. Okay, so please do that. Okay, so I think our first order of business is to approve the minutes from the April meeting. Hopefully you had a chance to review those. Does anyone have any questions or corrections on the minutes? Okay, is there a motion to approve the minutes from the April meeting?
So moved.
Is there a second?
Second.
Is there any discussion? Katie, will you please do roll call for the vote?
Absolutely. Helen Blanca,
Yes.
Chen Wei Chi,
Yes.
Deborah Diaz,
Yes.
Amy Fellows.
Yes.
Lauren George,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes.
Judy Richardson,
Yes.
and Cheryl Ramirez.
Yes.
Excellent. Okay, so next we have a report from our executive director, Morgan Calvin.
Wonderful. Well, thank you. A couple of updates of what I've been working on with staff. You know, this is a brand new venture at the Department of Business and Consumer Services. So a lot of what we've been doing is setting up the infrastructure. Last meeting was Jenny and Katie's second day on the job. So we've been doing a lot of orientation and grounding and making sure that Jenny and Katie are set up to support the board's work over the next 2.5 years. In addition, we've been working closely with the chair and vice chair to set up good communication systems and meet regularly again to get this effort started out right. And we've been working with our OHA partners, Devlin Prince and Laurel Swerdlow, to also start good communication there. So in addition, I think the other update I wanted to give, there were some questions and requests for an overview of the budget that we have for this effort. The budget that was given to the Department of Business and Consumer Services was about $1.5 million. That is in several large buckets. The first being staff, about a little over 600,000 of that is earmarked for staff. Another is supporting the board and board travel, and we have around $30,000 to support the board and board expenses. In addition, because some of the effort will be getting the policies and procedures set up and supporting our contracting, we have about $45,000 earmarked for the Department of Justice and legal expenses budgeted. And then I think the one where there's been the most interest right now, we have earmarked $500,000 to potentially $750,000 for contractors to support the work groups, to support the additional expertise that we'll need to be contracting for to support our work. So it's as much as 750 because we're still trying to figure out how much some of the other expenses, some of the upfront costs might be, and wherever possible, we've been trying to dedicate more money to that line item so that we could bring on additional expertise and knowledge. I'll pause right there and see if there's questions.
Just a request. Could we just get a quarterly budget report that gets our expenses and how much is being spent and how much money remains? Because I'm assuming what you're talking about is a 2-year budget.
That is our budget through June of 25.
Okay.
Yep.
And we got started late, so I think it would be really helpful to actually understand not how much money is actually being spent on a quarterly basis and how much money is available.
Happy to do that.
That'd be great. If we can get that in writing, that'd be
Yeah.
wonderful.
No problem.
Any other questions for Morgan? Great, thank you. So our next item of business is recruiting for the Executive Director Evaluation Committee. At the last board meeting, the board established a committee to set expectations for the director and evaluate her at least once a year. We need at least 3 board members to serve on this committee. It will start very soon. The first order of business of that committee will be to establish the expectations for our executive director and then move on to a yearly, at least yearly evaluation. Warren and I are both interested in serving on that committee, so we need at least 1 other member of this group, more if are interested, but at least 1 more. Is anyone interested in serving on that group?
Be happy to help.
Okay, great. Anyone else? No? Okay. Well, then I think we need a motion to recommend that the following board members, me, Helen Belanca, Warren George, and Bruce Goldberg serve on the ED Evaluation Committee.
So moved.
Is there a second?
Second.
Great, Judy, and any discussion? Okay, can we do a roll call?
Helen Belanca,
Yes.
Jen Wei Chi,
Yes.
Deborah Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes.
Judy Richardson,
Yes, and thank you.
and Cheryl Ramirez.
Yes.
Great, we're getting good at that already. Okay, so next we need to review our policies and procedures. I'm going to turn this over to Morgan so she can go over the edits. We sent out these policies to all the board members and requested your feedback on those policies. We received a number of suggested edits, and Morgan has kindly consolidated them onto one document so that we can review them.
Sure, thank you. So there are 2 sets of policies to review and for you to adopt. One is a general set of policies, and that's the one I'll spend most of the time on, since that's the area where there are changes and I think there are the most questions about. I did provide a overview of kind of the major areas where there are changes. I won't go into and repeat that, but I'm happy to answer any questions. I did want to focus on a couple of areas and talk about the changes. On page 5, there is additional language talking about our public comment process. That process is that for written public comment, we need to receive that prior to the board meeting, 72 hours prior to the board meeting. That is to help provide enough time for staff to collect all of that information, to put that together, and then to work with the DCBS communication folks on posting that on our website, and then making sure that board members have that material prior and enough time to review that prior to the meeting. So there's a little time for all of that work to get done. There's a 24-hour time frame for public comment from people participating virtually, similarly to make sure there's enough time for staff to know who those people are and to build enough time into pinning them and making sure to unmute them. And then, of course, anybody who comes to the meeting is welcome to sign up at the meeting and provide public comment at in-person meetings. Any questions about those changes? Another area of change was around the decision-making process. There is new language around consensus and trying to strive for consensus, and then language on how to have a vote, even when consensus is achieved, to have a roll call vote. And that is at the request or urging of our council to make sure, especially with hybrid meetings, that it's very clear that who's voting on what and how people are voting. So when people say yes, you know that they're there in the meeting and have voted and how they have voted. The participation section is new. That was suggested to make sure that there's some general expectations for board members, and how people, attend the meetings and that section is new. The, one I also wanted to highlight some changes to is on page 8, the interaction with media, lobbyists and interest groups. There's been some questions about this section in particular. This section does make it clear that no individual board member can speak on behalf of the board without requesting permission from the chair and the executive director. That is when there are specific requests to a board member to give a presentation where you would be sharing information on behalf of the board. That language does not prevent you as an individual, when you have existing relationships and organizations, to give updates of the work that you're participating in. And you would just want to make it clear that you're doing that as an individual, not speaking on behalf of the board. In addition, I think that section references additional work that would be done in community engagement that would be part of the work plan. There's no way to capture all of the outreach that might need to happen, especially with 4 board members who are dedicated to public engagement. We wanted to make sure that there was a more thoughtful part of our work, part of your work plan that would address how to do that community engagement.
Are we through with that section?
Yep.
I just wanted to add a couple of things. I think the board needs to adopt a longer range policy relative to speaking and outreach. And hope we can adopt that before long. Also, we'll report that it was mentioned by Chunwei at last meeting that he and I had received an invitation to speak at forum of the League of Women Voters, NAACP, and Mid Valley Healthcare Advocates. And based on the fact that the board had not yet adopted a policy, we declined that invitation. And I would also, for my own self, I think it's kind of important that we not say too much to others until we have done more to develop our own sense of things, and that includes our own. We have other people trying to talk to us. We want to talk to other people, and we want to be sure that we have a way to do that in a uniform way that encourages everybody and not just particular groups. So, thank you. I can live with what's here, with the provision that we develop a policy, a board policies soon on speaking and outreach.
Michelle, did you have a comment?
Yes, thank you. This is Michelle speaking. I agree with my colleague and those comments that were just made. I also had concerns and some questions about this section. I can also live with this section, and I absolutely agree that there is work to be done sooner rather than later in clarifying what that process looks like. I do have a request. If my colleagues on the board agree, I think it would be helpful to have some language developed that we can use that is consistent when we get those invitations or requests for an update, so that we can just let people know where we're at in the process, and that we absolutely value and are working towards a way to equitably and fairly and clearly communicate with stakeholders across the state that is part of our work, and that we will be working in our work plan to develop that strategy. That's something I'm personally very committed to and really excited to start work on. But I think in the meantime, there's a lot of interest, there's a lot of excitement about this work, and I think having some language that we can all use when we get those requests while we develop that additional policy and while we develop the strategy for outreach in the work plan would be really helpful.
Yes, thanks, Michelle. Yes, we've absolutely been talking about that. And I want to be clear too, that part of the policies is not in any way meant to suggest that we're not going to be talking to the public about our work. We absolutely will be. Community engagement is crucial to the work that we're doing. And we look forward to many of the board members' participation in the work plan development so that we can lay out a strategy for how we're going to do that. And I agree, we've already talked about that too, to have sort of a monthly updated sort of standardized script or talking points that we will be using when we talk to outside groups so that we're all on the same page. Yes, that's absolutely part of it, but yeah, thanks. Yeah, Amy, did you want to?
Yeah, the last part of what you just said is exactly what I was gonna ask for, if there could be some kind of like. Maybe after the minutes are done, bullet points of, these are things that, as we are in different
Yes.
groups that we, might be sharing, just so that we have a high level update.
Yeah.
I also was going to ask, and we might be getting into this later, because community engagement seems like it will be such a big part of the work plan. Is there potentially going to be a work group doing the strategy around
Yes,
community engagement? Okay.
yes. Yeah, and we can get into that when we're at the agenda item, yes. Yeah. Yeah, I anticipate that for our future board meetings, there will be a sort of a standing agenda item about community engagement in which we will do multiple things, hearing about the outreach that's happening, hearing about any requests that have come in for us to talk, and then also going over any sort of talking points that we want to share with the public. So yes, that will be a routine part of these meetings. And certainly we'll have a dedicated work group at some point about that. Yep. Can do the.
Yeah.
Any other comments on the public engagement part? I want to go back to another part of policies. Thank you. I can't see. Thank you. Chenwei, did you have a comment?
Yes, just very briefly related to public engagement. About 2 weeks ago, I was interviewed by OSU's campus media, the barometers about the Universal Health Plan and Governance Board. And at that time, I said very explicitly, I cannot speak on behalf of the board. And what I told the reporter was only what stated in the Senate Bill 1089. And then I elaborate explicitly saying what I'm saying is simply representing a public health professional, nothing representing the board. And since we don't have any adequate guideline, I think it would be helpful to have a good guideline when such as media approaching us. How do we respond that? On the one hand, we want to publicize our work, but at the same time, we are kind of walking in the fine line, not to encroaching our representativeness.
Yes, excellent point. Thank you, Chenwei. I appreciate that. That's a great approach to it. Any other comments on public engagement? Okay, I want to go back briefly to, did you? Okay, I want to go back briefly to what we were talking about decision-making. Obviously, as part of the work of this board, we will be taking a number of formal votes where they are recorded and there's a roll call. We've already, of course, done that several times today, and that will definitely be part of our process. But when we are discussing various topics, in addition to formal roll call voting, getting to consensus on an idea or a topic or an area we want to explore will probably come up. These are things that maybe we want to just get a read of the room on or get a sense of where people are in agreement or not in agreement, with the goal of having consensus as much as possible on the work moving forward. So this does not replace roll call voting, but it's a discussion strategy that we can use on this board to see where we all are and to get consensus. It's called Fist to Five. I can kind of explain it. It's a way of touching base with everyone in a group about where you are on a topic. One way that this could be used is if we bring up a topic and we want to just gauge where we all are on it. If we quickly see that there's broad consensus on a topic, we can move on and we don't have to spend a whole lot of time discussing it or going into detail about it. So this is a voting system that we could do very early on in a topic to gauge where we are starting from and see how much discussion is needed. And then toward the end of a discussion, we could also use this to gauge where there's still concerns, where we need more information, where we need future discussions on it. So it's a visual voting system where we would use a fist of 5 system to indicate how we feel about a certain topic. If you were to hold up 5 hands, it means you're in total agreement on this issue, you're enthusiastic about it, you would champion it. If you hold up 4 fingers about the issue, you very much are in favor of it, maybe some trivial minor hesitations about it, but very much in agreement. Holding up 3 fingers means you're pretty neutral about it. You don't have strong feelings either way. You're happy to go along with it. You don't, you're not strongly for it or against it. 2 and 1 are ways of signaling, not that you disagree necessarily, but that you have some serious reservations about the topic that we're talking about. And if someone's holding up a 2 or a 1, it means the extent of your concerns about this topic are such that we need to stop and have more discussion about it. It doesn't mean that you're going to oppose it. It means that possibly you could go along with it, but you're really requesting more in-depth discussion and being able to address your serious reservations. Holding up a fist means you're against this. You don't want this to move forward. You're actually willing to block this topic because you really don't think it should go forward. So that's kind of the system. In general, if we see 3s, 4s, and 5s on an issue, it means we can quickly move on. We don't need to discuss it anymore. If we see any 1s or 2s, that's our signal in this group that we're going to stop and pause, hear out your reservations, talk it through, and decide if we need to move on or take another vote. So it's just a way of sort of reading the room a little bit, and it's a very visual system. It encourages participation too, because a lot of times, we want to make sure that we hear from everybody, and in a meeting dynamic, sometimes that's hard to do. So it's a way of checking in with everyone on the board on a certain topic. Does anyone have questions on this idea of fist by voting? Yes, Cheryl.
I understand the fist to 5 voting, and I'm assuming we're always striving for consensus among the board.
Yes.
But it seems to me, I mean, just based on our task force experience, that there will be times where we won't have consensus. So at some point, are we going to vote on things and go with the majority if we're just not going to get to consensus on a particular issue?
Yes, absolutely. And I think the task force also had a good process for that, where if they were voting on an issue where there wasn't consensus, there was an ability for folks in the minority to express their opinion, to provide a written commentary, to provide an alternative to the ideas that the majority is going along with. And we would like to, that's included in the policies too, that we are interested in when we need to take a vote without consensus, allowing folks in the minority to also express their opinion.
Just to a slight clarification, the minority process didn't make it into the final draft of the policies. There's some language that was used from the task force that was really specific around recommendations that didn't fit with the general theme of the policies. So if we wanted, it could be a practice that you want to do, or if you want language specifically in the policies, we still need to go back and add that. So
Yeah.
just.
Yeah, I do. I think that's important. If we get to the point of recommendations to allow for that, I think we should have that. What's the read on the group on that? Is that, let's try a little fist to 5. When we can't reach consensus on an issue, should we allow for the minority, the folks in the minority to express their written opinion and any alternatives to the majority opinion? So you can raise your level of agreement with that. So I see on the screen, please help me because I can't see. We see a 4, a 5, and the Chenwei is a 5, is that right? Great. And then we've got 5s and 5s in the room. Excellent, excellent. So that's a great use of it, just to kind of, we don't need a formal vote, a roll call vote on that, but it's just a sense of, on this issue, do we all think that's the right thing to do? Cool.
Michelle.
Michelle?
My question then would be, that we have clarity in our guide, in our procedures for when we use FISTA 5, when we go to a formal vote and use that minority opinion process, just so our decision-making process is really clear when we're using which form of decision-making.
Yes, absolutely. And I think Morgan's been great. She'll always have in the agenda when we need like a formal approval of something or, when there's a vote, when there's a formal vote going to happen. FISTA 5 is much more of a casual sort of checking the read on the room kind of thing. So, we can use FISTA 5 and formal voting on the more serious topics. And if anybody at any time feels like a more formal roll call vote is needed, any board member can request that. And I believe according to Robert's rules, if somebody requests a formal vote and there's a second, we will consider doing a formal vote on it. So if we are using a consensus-based process and somebody would like it to be recorded, we could do that. But otherwise, it's just a chance to gauge where we are in the discussion and allow everybody to chime in with where they are.
So what you're saying is we want that language placed into the policy and procedures.
Which language?
The language about minority.
Yes. Yes.
And so I added to add language specific to adding the minority report or a minority opinion into this process. This process does outline, that a consensus decision-making approach will be used. It doesn't say how, so it is not as
Right.
specific as FISTA 5, because there may be times when you want to use FISTA 5 where you don't want to, it's not a formal decision, it's just a kind of preliminary decision. So that is not included in the policies. The policies do say, even when there is consensus, you still need a roll call, because that's where Jake has recommended that we capture that consensus in a roll call vote. So there, even when there is consensus, there would still be the need to take a specific vote.
I think the question that was being raised is that there may be a disagreement on whether we're dealing with something casual or something that should be voted on formally. Certainly, anything formally is going to take a roll call vote. And as chair, it's certainly our intention to follow that. But if we are doing something, anyone has the power to move from FISTA 5 formal, if you will. That's how we want to be able to structure decision making.
Any other thoughts or questions on decision making or voting? Okay.
So I will take these policies, add some language around a specific process for capturing a minority view and bring these back for approval at the next meeting.
And we can't approve them, we'll just understand that addition or should be.
I would advise that you bring them
Bring
back, just
Okay.
because they're the policies and it seems like the language is important, so I would and then if there are specific word tweaking at the next meeting, if I didn't get it 100% right, I think we can do that once there's some language to start from. But the second policies, there have not been any changes or any additional recommendations. This is a delegation policy that delegates to the executive director and staff compliance with public meeting laws and posting of agendas and materials and responding to public records requests, and kind of overall board administration and maintaining the website and making sure that materials and information is available for the public. I did not receive any feedback or comments on that policy, so if the board wanted, you could still approve that policy today.
Can I just go back to the other policy, just for
Yes.
clarification, not on the voting, but on the subcommittees and committees? I just want to clarify that it doesn't say one way or another. So I just wanted to clarify that those committees can be populated by people outside of the board.
That's been our understanding all along. Do you think it needs to be explicit in there?
Uh,
Yeah, okay.
I think it'd be
With
good.
approval of the board.
Yeah, the board appoints them,
Okay.
but that they're not, it's not just simply board members that will be on committees and subcommittees and advisory committees. Great.
That's our understanding. Would you wish language to
Yeah.
be correctly clarify that?
Okay.
Yeah, I think that'd be good. We're gonna adopt them.
Might as well be clear.
Yeah,
Yes.
it's just silent.
And the Senate Bill 1089 says the authority to appoint committees lies with the board and to determine membership lies with the board. So my read would be that it would be up to the board on who would sit on those committees, but I'm happy to add language that says this could be board members or outside of the board participation.
The previous task force had the same language and chose to only have board members. And I just wanted to do a temperature check on that to be certain that we could expand that with this board, which I think would be important.
Yeah, let's do a read on that. Do the board members agree that our work groups and committees should be open to outside members and not just board members? Let's do a fist of 5 on that. We got 3 5s virtually, 5 5 5 5 5 5 in the room. Yay. Okay,
Great.
good. Great. So to be clear, we have 2 sets of policies. One is our general policies and procedures. We are not approving those today. Morgan's going to add some language around our committee work group composition and around the minority vote when there's not consensus. And we'll come back at the next meeting to approve those. But the second set of policies is around our delegation policies of what we're delegating to our executive director and staff. So I think at this point, we need a motion to approve that the policies around delegation to the executive director and staff.
Motion to approve.
Second,
Second, is there any discussion on those policies? Okay, we need a roll call vote for that.
Ellen Blanca,
Yes.
Chen Wei Chi,
Yes.
Deborah Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Bruce Wilford,
yes.
Judy Richardson,
Yes.
Carol Ramirez.
Yes.
Okay, great.
And just to let the board know, after approval, I will send these to the DCBS communications team for copy editing. And then I will add the dates that they were approved and we will post them on our website as part of the board's operating policies.
Great. Thank
Michelle,
you.
that's right.
Oh, Michelle, yes.
Thank you. I just wanted to go back for clarification, the suggestion that we include language in our policies, clarifying that we do the decision, the informal consensus that we all just took on including non-board members in subcommittees. I think, did that get decided that it's going into not the policies we're voting on today, but our other policies that we'll be voting on next month?
Yes.
Okay, great. Thank you.
And I'm really grateful for my allies here in the room. My eyes are terrible. And so if there's a board member who's participating virtually and you have your hand up and we're moving on and you haven't been recognized, please speak up because I sometimes can't see the hand. But yes, thank you.
I'll watch right now.
Thank you. Okay, great. Okay, so moving on, per the board's request, we have a presentation from Devlin Prince from the Oregon Health Authority. We're grateful to have Devlin as part of the OHA team that's helping us with this work, and we've asked him to give us a high-level overview of the status of health insurance coverage in Oregon, some of the cost challenges with accessing care, and the current efforts that are underway at OHA to provide coverage. Since Devlin is remote, let's please hold off on questions until the end. If you're able, perhaps if you have a question about a certain slide, perhaps you could jot down the slide number or the slide title, and we can go back to that at the end, but we'll let him go through the whole presentation first and then take questions. Okay, turning it over to Devlin. Thank you for joining us, Devlin.
Hi, everyone. So please interrupt me if you can't hear me well. I am working on one screen here. So yeah, for all those that do not know me or haven't met me yet, I'm Devlin Prince, he, him pronouns. I'm a senior policy analyst at the Oregon Health Authority, joined here with my colleague Laurel Swerdlow, who's our health policy coverage team lead. So the two of us had the honor of working on the 770 Universal Healthcare Task Force, and we're now here to continue our support with the board. So as was said, I'm going to take you through a very high level overview of healthcare coverage in Oregon. And I know, and the goal for this is so that you can all get a snapshot of some of the numbers and reports that exist out there, as well as recognize any of the subject matter expertise that lies within OHA that we would be happy to do a deeper dive in at a future point. So I'll do a breakdown of coverage. I'll specifically talk about the uninsured population, talk about healthcare costs and affordability, and then just overview of some current projects and programs that are happening. Next slide. So I just wanted to have this slide of general coverage in the United States. The key points that focus on here, I think, is that 7.9% was the uninsured rate in 2022. Employment-based coverage was about 54%, and then that follows with Medicaid and Medicare as the next largest coverage in the United States at 18.8% and 18.7% respectively. Next slide. So coverage in Oregon. In 2021, this is from our Oregon Health Insurance Survey, OHIS, and I am using these numbers. The survey happens every 2 years, so the 2023 numbers are not quite ready. And as soon as they are, I will be happy to share that with you all. So 95.4% of people in Oregon were insured, and the remaining 4.6% were uninsured for various reasons, and I will get into those later on. Next slide. The breakdown from the insured in our state, some key points are people who have insurance from an employer or group make up 47.2%, which is below the US employer percentage, which was about 54.5%. About 45% of people in Oregon receive public health care through Medicare or Medicaid. That's combined. And then our Oregon Health Plan, which is our Medicaid program, accounts for about 29% specifically. Since these numbers are from 2021 with the public health emergency unwinding and through the redeterminations, we do know that a lot of these people, a lot more have stayed on OHP, more than what was anticipated. Next slide. So going in specifically to our Oregon Health Plan, OHP, these numbers come from April 2024, 1.3 million on Medicaid. That includes our CHIP, which is our Children Health Insurance Program. Healthier Oregon, which is the program that covers people regardless of their immigration status. There's about 85,000, and children are included in that. And then in the future, we will have OHP Bridge, which is going to start in July of this year. That's currently, we have an estimate of about 33,000 there. And those are people who are currently enrolled in the temporary Medicaid expansion. And by 2027, OHP Bridge is anticipated to cover about 100,000 people. Next slide. High level numbers. So 1.4 million people are enrolled in OHP. 33% of Oregon's population are on OHP. 56% of children in Oregon are enrolled in OHP. 91.6% get their care through coordinated care organizations, and 8.5% are considered dual eligible, meaning they are on both Medicaid and Medicare. Next slide. Just wanted to do high-level demographics that we have from the same group. About 47% of OHP members are white, and then that follows by 16% who are Hispanic. Black OHP members make up about 3%, Asian members 3%, American Indian and Alaska Native 2%, and Native Hawaiian or Pacific Islander 1%. And then the ages, as you can see, 10% 0 to 5, 24% 6 to 18. And then the majority are above that. Next slide. So to specifically talk about the uninsured population, as I mentioned, it's about 4.6%. And the biggest reason that people said that they were uninsured was that they were uninterested. The next largest is that they lost OHP coverage, and that's a really important piece to remember. And we'll get into some of the current programs and projects that OHA is doing to look at this loss of OHP coverage. The next discussion is the premiums are too expensive. People lost their job. Your employer stopped offering the coverage, or reduced work hours no longer made them eligible for having coverage. Next slide. So in 2021, most people in Oregon who did not have health insurance were eligible for help getting health insurance through the marketplace or OHP. So you can read this slide. Let's take the 18 years and under, which is the second column there. The dark blue, 61.0%. So of those without insurance, 61% were eligible for OHP at the time of this survey. Next slide. So now we'll go into healthcare costs and affordability, and there are many reports and different numbers and how this is decided and figured out. What I'm sharing here comes from our 2023 Oregon Cost Growth Target annual report. So in 2021, total healthcare spending in Oregon totaled $31 billion. Between 2020 and 2021, total healthcare expenditures increased by 3.5%. And then per person, the commercial market grew 12.1%. Medicare grew 6.5%. Medicaid spending decreased by 2% due to the increased enrollment. And so of this 31 billion, one of the big key things I think stands out is that Medicare makes up a large chunk of this. Next slide. In 2021, employees paid 13% of their premium costs for a single plan and 28% for a family plan. This slide also shows the years leading up to 2021. Next slide. So in addition to those premiums that everyone was paying, consumers also pay for the cost of sharing. So in 2022, the average consumer in Oregon paid about $776 in cost sharing, which accounted for 13.6% of their healthcare costs. And in that is the deductible, co-insurance, and copay. Next slide. So looking at both the premiums from before and deductibles, for a family, the cost burden was about 13%, and for a single person, it was about 5%. And this is only looking at the commercial health insurance side of things. And I know I'm moving quickly through these, but it's just so that we can all talk about it and discuss anything that we want to know more about. So next slide. Where's the money going? So in 2021, almost 40% of healthcare spending in Oregon was for hospital services. So that's both inpatient and outpatient. Next slide. And so the percent of Oregon adults reporting delaying or foregoing healthcare costs due to the costs. This is Alterum's Consumer Experience Healthcare Survey. So about a third of Oregon adults said they skipped needed dental care, delayed going to a doctor or getting a procedure, or avoided care due to costs. 1 in 4 adults said they skipped doses of medicine or did not fill a prescription. Next slide. And this is an overview slide. I will not go into detail on all of these, but we are happy to do that. I personally get to work on the Healthier Oregon program. Laurel works on OHP Bridge. We have team members that do the Cost Growth Target program, and then we have other team members that work on the new Medicaid demonstration waiver. So the cost growth target program, created in 2019, sets the sustainable healthcare cost growth target. The Medicaid works started in July of 2023, continuous eligibility for children 6 and under, and then 2-year renewal cycle for anybody older than 6. In 2024 and into 2025, we'll start the health-related social needs benefits, which are going to be benefits related to climate, nutrition, and housing. So between the cost growth target and the Medicaid waiver, it's all to look at helping out with churn and with costs. OHP Bridge also is here to help with churn and coverage. So OHP Bridge for people income up to 200% FPL, that'll start in July of this year. They're more likely to be insured or fall in and out of healthcare coverage due to their income changes. And then Healthier Oregon program, full OHP benefits regardless of immigration status, started in July of 2023. And one of the key things I wanted to highlight in this is that all of these are new within the last 5 years. And these are all some of the major projects and programs that OHA is working on, and that you will all probably want to discuss more as you move forward and talking about building out the proposal for the universal health plan. And I would add the 5th body of work that you all are doing as the Universal Health Plan Governance Board, and tackling all 3 of these, right? Coverage, costs, and churn. And Laurel, is there anything else you would want to add?
Yeah, hi everyone. Again, Laurel Swerdlow, and her pronouns. I, as Devlin said, helped support the 770 task force several years ago, and I'm thrilled to be back here in my current role supporting the health policy coverage team. I think the main piece, kind of like one of the main takeaways that I would want to underscore is kind of the opportunities that I think we see in this presentation. You know, the board actually asked OHA to pull together kind of an overview of the various coverage programs that we have. And when you look at this picture just from a coverage perspective, Oregon's doing pretty good compared to, you know, nationwide rates. Nationwide, we're looking at uninsurance rates closer to 7.7%. In Oregon, we're in the 4 to 4.5% range. So when you look just at coverage, I think as a state, we're continuing to inch closer and closer to what could be considered full coverage for the state. I think what we really see in this presentation is there definitely is real opportunities when it comes to cost, which is why the legislature directed OHA to create the cost growth target program, and why OHA is really trying to lean into the cost space. When the board asked for us to present a presentation on coverage, my first thought was, if we only present coverage, I know that the response back will be, sure, folks are covered, but what does that coverage look like? And that's really why we wanted to make sure to still include pieces around cost sharing and around cost, because I know that that's also a critical component to the work of the board. So just wanted to offer kind of that high level overview or takeaway, if you will.
Thank you. Yeah. Let's talk. Any questions?
Yes, Devlin, this is Helen. Does the cost growth target program only apply to OHP, or does it apply across all businesses?
Across the state.
It's across the state, so it's all lines of business. So commercial plans like that everybody's, because the that 3.4% growth was part of the CCO waiver originally, right? So that's been in place longer for OHP.
I believe so, yes.
And how are we doing in terms of meeting that target?
So last year kind of was our first look at it, and it was 3.5%. So it was 0.1% higher than the 3.4 that we're going for.
Across all lines of business?
Yes.
Laurel, do you know specifically?
Well, one thing that I do want to add and just reinforce is we have a wide range of analysts on our team who would love to come back to offer deep dives into any of this work. So I could easily imagine kind of a question and answer session in which Devlin and I are doing our best to try to represent all of the various SMEs on our team. So I definitely underscore what Devlin just noted, that 3.5% is across all businesses. And I know that the cost growth target team would love to come back to dig into that further.
Bruce?
Well, just a comment, I to amplify sort of what Laurel said, but I think to take us perhaps in a little bit of a different direction. You know, one, we've been on this quest for coverage in this country since 1965. We had Medicare and Medicaid in 1965. Then we had the Affordable Care Act in 2010. We're trying to get people covered, but we've lost sight of the real issue, which is we have a totally broken healthcare system. And whether the cost growth is 1%, 3%, 8%, the fact that 1 in 3 people in this state delay getting care or say they can't afford care means we have a tremendous problem. And putting more people into this sick system, you've got to start to question what we've been doing. I didn't even mention things like dental care. Cheryl, I know, can talk tremendously about the lack of access to behavioral health care. So in a certain way, the coverage is kind of meaningless because it's empty coverage if a third of people can't get it and are having issues with costs. And I would say the cost growth target hasn't made a dent in the unaffordability. We have a basic unaffordability problem. If we keep things at 3%, I'm not sure we're going to see a dramatic increase in the number of people that can afford healthcare. Because all we're doing is limiting the growth. So I just think as we go forward as a board, we have to think about how we actually change our healthcare system so people can get the care that they need. And so healthcare is affordable, because at this point, you know, to me, all of our sort of dials of our healthcare system's health are kind of in the red.
Yeah, Amy.
Thanks for the presentation. I was wondering on the kind of future project piece, a couple kind of up and coming things if someone in your group is, you know, going to be tracking, is how the Medicaid billing in the schools will impact this, and also kind of on the care delivery side that Bruce just spoke to. And then Senator Gelser-Bowen's Culture of Yes bill that expanded OHP accessing the Affordable Care Act, the K plan on the mental health side. It used to be called Psych Under 21, which allows families with kids with consistent mental health challenges to access OHP and other supports using the K plan. And just if those are two things that you're going to be kind of tracking and moving forward on how it will impact everything you showed us.
Yeah, so for the Culture of Yes bill, I do know the team that's starting to work on that and would be happy to get them to come in here once they get underway.
Thanks.
I see Chen Wei
Okay.
has his hand up.
I have a question on the page 17 about the total cost burden. Page 17, the total cost burden. The slide 17.
It looks like on our deck, slide 17 that we're looking at here is a title slide.
The document we see, okay, the title for that slide I have question is the total cost burden commercial health insurance is expensive.
It's one of the green slides.
maybe keep going through. I'm not sure who's. If you could keep going through the slides. Oh. There
Yes,
we go.
Right there.
Yeah.
Yes. So my question is, whether you have investigated, this is the average, and I'm interested in the breakdown by income group, such as quintile or decile, because we know the average doesn't tell much story. We want to know the detailed story is how does, say, people in the bottom 20% versus the top 20% in terms of their financial burden, the percentage of their income spent in the premium plus deductible. And this information will be very helpful for the board, because as we design the universal health plan, we want to make sure in terms of the financial burden under the universal health plan, it will be fare much better than under the current commercial health plan in terms of the financial burden by income groups.
I will just reiterate also what Laurel had said earlier is we have a whole cost growth team. The link to the entire report is there on the slide, and it does go into further detail on a lot of other things. But I'm sure that they would love to come in and discuss any type of further breakdown that they have on this.
Thank you.
I have just a couple of things, comments and things to add to our questions list. One is I note you're estimating 31 billion, which is about 8,000 per person. And that is quite short of the national estimates for healthcare expenditures in Oregon of 12 to 13,000 per person. So I don't know if you're prepared to answer that, but we will want to know what's included or how to get from one number to the other. And also, I was interested in more information on the number of uninsured. And there was a breakdown by reasons people gave for not having insurance. Of interest to us is how many of those are eligible for the Oregon Health Plan and have not signed up. If to the extent that there are healthy people who are eligible, that could represent a revenue shortfall in Oregon relative to other states, depending on it would seem like we should be getting people signed up who are eligible, so we can get that money. And if you know the churn rate for the Oregon Health Plan, that would be interesting. And just one comment. Many of these programs, I understand how they've grown up and the value that they have, but a little bit of our mission is the opposite direction of new small programs. We want to change from fragmentation to a universal program. So do you have any comment or answer to any of that? Thank you, Devlin.
Yes, Devlin, shall I jump in here? Yeah, so to your question about the discrepancy between cost analyses, Warren, I would love to let's check in on the source that you're referencing of the cost that has that discrepancy. And then I'd like to reiterate, if you would like to dig into cost, I think our cost growth target team would be the folks for that. And I'm hearing that perhaps that would be helpful. So maybe we can check in on that piece. With respect to churn, churn is something that OHA has really been focusing on, especially as we move through what's called the public health emergency unwinding. Just some churn rates to speak to your question there. In 2019, about a third of folks were enrolling in OHP after having left within the past 6 months. So about a third of folks were turning on and off OHP, 34 of those enrollees. So 34% of people enrolling in OHP were returning after less than a year. A quarter were returning within a year. So a quarter of people enrolling in OHP were returning within that year. So that churn is absolutely something that we've been focusing on. And as Devlin said, there are really 2 programs that we're rolling out to try to address churn. The first is OHP Bridge. That's the program that Devlin was referencing that will cover adults age 19 to 64. OHP Bridge will utilize the Basic Health Program Authority that's authorized under Section 1331 of the Affordable Care Act. And Oregon is anticipated to launch that program in July. We will be the 3rd state to have a program of that nature. We additionally have in our waiver a continuous eligibility provision that allows for folks up to age 6 to have continuous coverage on OHP up to age 6, and above age 6 to have enrollment periods that last for 2 years. So we have continuous eligibility for 2-year periods, which means that if folks' income fluctuates above or below that limit, they will be able to stay on OHP during those 2-year continuous eligibility periods. So those are sort of the 2 ways that we're working to address churn.
Thank you.
Go ahead, Bruce.
Hey, Laurel and Devlin, just to again focus on the cost piece. You may not know it, but just a request, if we could get from the cost folks the out-of-pocket costs and how they've grown over the last 10 years in the commercial market. That would be really helpful. I know that the cost growth group and the cost growth program is focusing on total cost growth, but you can reduce total cost, but consumer percentage of that in terms of out-of-pocket costs, in terms of increased deductible and increased copays can show a different kind of story. So it'd really be helpful to see what those out-of-pocket costs have done in commercial health plan, not in OHP, because we know there isn't the same out-of-pocket costs, but that'd be really helpful. And then the other question, and I don't know if you have an answer to this now, or we have to get it from the cost growth folks, is so what is the cost growth target doing around individual out-of-pocket costs? Any sense of that?
Devlin, would you like for me to? Oh, go for it.
Hey, no, go ahead, Laurel. I was taking notes to take back to our cost growth team.
Yeah, so to your first question, Bruce, can we go to our out-of-pocket slide? And I don't have the number offhand, and I can try to look to. Can you scroll down through this? Oh yeah, one more. Yes. Oh, yes. Oh,
Back up.
I think it's 23. Yeah. So Bruce, are you sort of asking to look at this type of data, but projected over kind of the past 10 years?
Yes, but also as percentage growth in out-of-pocket, we're talking about keeping healthcare cost growth at 3.4%.
Yeah.
Has consumer out-of-pocket kept to 3.4%?
I'm tracking your question. Yeah, that's kind of the second piece, right? Around how.
So it's not this, I get this. But it's that other piece as well. I think digging into more detail about out-of-pocket costs, because that's ultimately what matters.
Yeah, appreciate that. So we can absolutely try to kind of get this type of data trended, see what we can do with respect to this data trended. To your first question, to your second question about, sorry, did I miss something?
No, because I just want to see how that's grown over the last 10 years. You know, my sense is, what I've seen is out-of-pocket costs have grown at a much steeper rate than total healthcare costs.
Yeah.
Costs have been shifted onto consumers.
Yep, I hear you. So for the first, for that first question that you're asking, we can absolutely look at this, trying to see this data trended. And then to your second question, I definitely would want to defer to our cost growth target team to talk through how out-of-pocket costs are being wrapped into the general cost growth target program. So could absolutely find some folks to join in a future meeting to speak more directly to that.
I see Michelle has hand up, and then we're about out of time for the subject.
Michelle, go ahead.
Thank you. Thanks for this great presentation. I am curious if there is, and I did try and click through to some of the report links, haven't found it yet, but curious, and you may not know off the top of your head, was there a drill down for the 2% of Oregonians who said that they were not interested in coverage, as to why they were not interested? It looks like, because Oregon has gone forward with planning for a goal of 98% coverage, that the assumption was that those folks would never be interested. But I think connected to this conversation about cost and about having coverage in name only for high deductible plans and things of that nature, if there was any indication of whether cost was a concern for the folks who were not interested, and or access if they lived in more remote rural parts of the state where they may not have the providers that they would need to see for their healthcare needs. Do you know if there was any further drill down in that data?
Not know off the top of my head, but I know that we can get the health insurance survey team as well when the new numbers come out. Laurel, do you happen to know?
I don't know specifically about how the OHIS instrument operates with respect to this question, but one piece that I do want to note is in other surveys and kind of research globally on total coverage rates, it is oftentimes you will see in other countries that there is some gap between total 100% and what the actual coverage rate is, even in countries that have universal coverage. There is some number of folks who are going to be off the grid, who are going to be, you know, not interested in engaging in any type of healthcare system. And I think it's very likely that story is unique in Oregon, as it is unique in every space. So we'd be happy to drill down further into that.
Thank you. And then similarly curious if the question that was asked earlier about the discrepancy between the spending per person in Oregon on healthcare versus the national, curious if that also reflects the fact that we have urban centers with concentrated healthcare provider networks, and then we have Eastern Oregon and kind of our remote rural areas where provider access is a challenge. Curious if some of that discrepancy in spending per person could be a reflection of where our healthcare workforce is concentrated and not. As that is something I think that this board will have to look at in terms of what meaningful access might look like across the state. So if you are going back and finding that data, I would be also interested if that was maybe a piece of that story. Thank you.
Okay, Judy, and then that'll be the last question on this topic.
Yeah.
Oh,
I just have a comment.
okay. Let's have Judy first, and then Cheryl, and then we'll move on.
Thank you. I was just going to offer, it looks like the OHA just posted their April report about patient cost sharing on the website under the healthcare cost growth target data. And Bruce, I am seeing a graph in there that's year over year out of pocket spending per patient, both for commercial market. So that may be a resource that will be helpful to us.
Great.
And then Cheryl.
I just want to make a comment that I think if we disaggregated these responses by age group, we'd have some answers there, especially in the not interested, premiums too expensive.
In race and ethnicity.
Yes.
Okay, thank you so much to Devlin and to Laurel for your time today and presenting to this group. We look forward to continuing to work with you. I'm sure you'll still be very much involved. So thank you very much for your presentation today, and we will talk with you soon.
Thank you.
So next on our agenda, as I'm sure you're all aware, the Joint Task Force on Universal Healthcare produced a detailed report and recommendations for this group, and those recommendations are the primary foundation for our work. We're lucky to have 3 task force members on this board, including Dr. Bruce Goldberg and Warren George and Cheryl Ramirez. And we've asked Bruce to present to us today on the work of that task force and its recommendations, and an overview. So can I hand it over to you?
Sure, and I'm gonna ask Cheryl and Warren just to chime in whenever to add things I missed, correct things I may have gotten wrong, and to just add any more information. So I'm gonna go through things pretty quickly. Gonna start with the board itself. As you can see, we already have a leg up as terms of we're a much snazzier looking group, but this was the group. We were established under Oregon Senate Bill 770. We had 20 members, 4 legislators, 13 of us appointed by the governor, and 2 executive branch and 1 local government person. And I think that kind of speaks to, we were a larger group, and that's some of the reasons why some members wanted to keep subcommittees to board members. My sense is we needed some greater outside expertise, but looks like we're going to get that with this group. Next slide. You know, I think we established kind of a context for the work, which I think was really important. And, you know, some of it we started to mirror in some of the discussion we just had, which was, you know, that, you know, we can talk about coverage and all of that, but fundamentally our current healthcare system is financially unsustainable, harmfully complex, and socially unjust. And I think this was a key piece of it. Also, that healthcare in Oregon is inequitably delivered and paid for. You know, that we have a broken financing system. We pay more for healthcare for people who are insured, well commercially insured, and we pay less for the elderly and for low income individuals. I mean, it's just it's by definition and an inequitable and a socially unjust system when we pay providers less for Medicare than we do for those who are commercially insured. And that too many Oregonians, because of their race, age, income, geography, insurance coverage, have vastly different outcomes in healthcare. So this was kind of the context that we all agreed on. Next slide. We talked about, we've already started to talk about the importance of public engagement. The task force put a lot of resource and time into public engagement, and quite frankly, it wasn't enough. But we had a consumer advisory committee that advised the task force. We had 7 roundtables with underserved communities, historically underserved communities around the state, rural populations, Latino populations, African American, tribal groups, et cetera. We had 6 regional community listening sessions around the state, including one that was conducted totally in Spanish. We had forums with healthcare professionals, hospitals and health systems, large employers, small employers, unions. I will say that the participation, while it was robust and great ideas from all of that, could have been better in terms of numbers of people involved. We did have a good contractor who helped us organize all of this. Next slide. Here's a summary of what we came up with. And we'll go through all of these in detail, but let me first be clear that what our charge was. We had a clear legislative charge to create a single payer system. It's actually a little different from our legislative charge, which is to create a universal health plan, which may or may not be what we recommend as a single payer plan. It's, I think, something we're going to need to work through, but our legislative charge was to create a single payer system. And we did that. And we put together a plan that covers all Oregonians, everyone automatically covered. It had a robust universal benefit for everyone, the same benefit, not like our current system where all of us have different benefits. We eliminated out-of-pocket costs, no copays, deductibles, co-insurance, or any other out-of-pocket costs. Same payment system for all providers, eliminating that structural inequity that I just talked about, that we pay the same for a Medicare patient as we would for a 30-year-old employed individual. Providers bill one entity. Oregonians can seek services from any provider in the state, no longer requiring specific networks. As you'll see as we get into things, the cost of putting together a system like this was slightly lower than what the cost would be of continuing our current system. Next slide. So let me go through some of those key elements. Next slide. So first, eligibility, as I mentioned, all people who live in Oregon would qualify no matter their job, no matter their income, no matter their immigration status. This does away with employer-based coverage. In terms of affordability, as I mentioned before, no payment at point of care, no copays or deductibles, no more medical debt, no more people delaying getting care because they couldn't afford it. In terms of the benefit, we spent a lot of time trying to figure out how we would put together a benefit. As you can imagine, incredibly both time consuming and needing a lot of expertise to go service by service by service by service. In the end, we decided to provide a benefit that was based on the same benefit as Oregon public employees. The reason is it was, we could expeditiously do that. It was felt to be a robust, good benefit. It includes a robust oral health benefit. The one thing that we felt needed to be enhanced was an enhanced behavioral health benefit. We didn't have the time to really detail that, but came up with a strong statement that the benefit needed to have an enhanced behavioral health benefit. One benefit we didn't cover is long-term care. Long-term care is covered in Medicaid. It is really not covered in many of our other insurance programs, certainly not in Medicare and most insurance coverage. We decided that it was just a very complex issue, and we can discuss it more at a later time, but to continue the same Medicaid-based long-term care benefit and not to include it at the time being, but to study it. I'd say on the 5-finger test, I would say members of the task force were all probably somewhere around 1, 2, and 3 on that, in terms of not very comfortable with that decision, continuing a decision where people have to bankrupt themselves to get on Medicaid, to get long-term care. But the complexities of that and the time and the resources we had were just such that we did not include that. Next slide.
Bruce, can I interrupt you quick?
Yeah.
Are you saying that the task force wanted long-term care to be included and was frustrated that it was kind of not discussed or?
I'd say that, yeah, from a moral and an ethical standpoint, yeah, most people wanted to see it covered. However, I think the costs of that were a real issue because currently, much like the rest of healthcare, where at least some of it is paid for, it isn't currently paid for. There weren't resources for that. And so there were some concerns about that.
And my recollection of that discussion was a feeling that if the task force tried to do too much, it wouldn't achieve anything. Yeah. And that long-term care is in so many ways a difficult piece that would have prevented us from getting far enough on the other aspects.
Okay, providers, I think there was a slide for this. Yeah, so in terms of healthcare professionals, any licensed or authorized clinician in Oregon who provides healthcare services that are covered by the Universal Health Plan was by definition a quote participating provider. That individuals could see any participating provider. That participating providers in the plan would not be allowed to give preferential treatment to private pay patients or to charge more for their care. As you know, in some other countries, there's an ability for there to have a private system where people can pay out of pocket, get better access, etc. We eliminated that option, that if you are a participating provider, if you are providing a universal health plan covered service, that Oregon PEB covered service, you couldn't charge more for that than what the going rate was in the state. If you were taking care of someone and paying and providing care for something that wasn't covered by the Universal Health Plan, so certain cosmetic surgeries, etc., you could charge whatever you want. That the Universal Health Plan would prioritize recruitment of a diverse and representative workforce with sufficient geographic and cultural distribution of providers. Now we can get to the next slide. In terms of provider reimbursement, the Universal Health Plan would reimburse providers directly. Methods and rates of reimbursement would be regionally based on certain different needs in parts of the state where there was a need to attract providers. Capitated models and other alternative payment methodologies could be used. There was a lot of discussion amongst the task force members about this. Really created an opportunity for clinicians to work in collaboration with the Universal Health Plan about how to pay, about quality improvement, etc. Right now, if you're a clinician, you have 20, 30, 40 different contracts with different payers, all of which have different payment methodologies, all of which have different utilization review criteria, all of which have different quality standards. And this created a real opportunity for clinicians to work in collaboration with one payer and to collaboratively come up with one way to sort of deal with what are important issues in our healthcare system. Next slide. Governance. The Universal Health Plan would be administered by a state single payer entity and governed by a nonprofit public corporation, subject to public records and public meeting laws. Board members appointed by the governor and confirmed by the legislature. We did recommend that there be regional entities that would advise the plan on how to respond to the unique needs of diverse communities around the state, and that there needed to be a clear government to government relationship with tribes. Next slide. Private insurance. Private insurance would have a very limited role in the plan that the task force put together. Insurers would be able to offer complementary insurance. In other words, they could offer coverage for benefits not offered by the universal health plan. Long-term care, for example. Certain prescription drugs that might not be covered by the universal plan. That there are some coverage limits, and they could provide coverage to beyond the coverage limits for certain services. Insurance companies would be prohibited in offering substitutive and supplementary insurance, and that the universal health plan could contract with third parties, including private carriers, for benefit administration. Next slide. Equity, a lot of discussion around equity. The plan removed obstacles to equitable care because one, now everybody would have the same coverage, the same benefit, no cost sharing, and provider payments would now be equitable regardless of what population you belong to. Removed a number of structural inequities in our current health payment system. No longer are providers paid more to see well insured, as I mentioned. Contributions, and we'll get to revenue for the plan, it's based on ability to pay. There's still, however, a recognition that we have tremendous inequities and disparities in care, and that the plan would need to work to come up with ways to address the disparities and to help to address many of the factors that contribute to that, which is income, education, nutrition, violence, and racism. Next slide. We had got some help in doing this work from a number of experts. We had an actuarial consultant, Optimus, who put together some of the cost data. The Legislative Revenue Office helped us with revenue estimates. We got help in dealing with ERISA and the financial analysis from Professors Fussy Brown and McCuskey, as well as Dr. Chow and Liu, who are nationally recognized health economists and experts in universal healthcare. Next slide. ERISA. Go through this quickly. Obviously, a big challenge to putting together any kind of a universal health plan. We felt that we found sort of a sweet spot that would be able to survive an ERISA challenge. That a recognition that there would no doubt be an ERISA challenge, but we felt that we could survive an ERISA challenge because one, we're funding the tax by a payroll tax levied on all employers. So all employers would need to pay the payroll tax. That it would be progressive. It would be based on employees' wages and unrelated, and this is important, to the employer's benefit plan and not contingent on it. The other key piece is that employers would still have the option to offer a self-funded plan should they want to. Our sense was, however, that although employers would have the option to offer a self-funded plan, that since we were offering a plan that probably had as good, if not a better benefit than almost every employer in the state, and because they were paying for that now through a payroll tax, that it would be unlikely that they would choose to offer their own self-funded plan and pay for it. Rather, we felt that they would offer some sort of complementary coverage. But if they were to offer a self-funded plan, we were prepared to accept that small dent in the universal health plan because it would avoid an ERISA challenge. Next slide. Costs. So I was surprised by our cost estimate. You know, when you think about putting together a single payer plan that did away with all of the cost sharing that we just talked about, people going bankrupt because they have, you know, $5,000 and $10,000 deductible plan. I was actually quite surprised by where our costs ended up, but we had Optimus put together the costs based on the plan that we put together. And what they did is they took healthcare data from 2019. And, you know, remember, we were meeting in 21 and 22. So the best data, the fullest data set they had was from 2019. So they took healthcare expenditures, actual Oregon healthcare expenditures from 2019, and projected those forward to 2026. And they also, so they based it on what our plan would cost and did that work. And they also looked at the estimates of what the current Oregon system would cost in 2026. Next slide. And what you'll see is that their actuarial analysis showed that our current system in 2026 would cost $55.6 billion. And that the universal health plan would cost $54.6 billion, a savings of about close to $1 billion, 980 million per year. Next slide. So important is to understand where those cost savings come from. And the vast majority of those savings come from savings in provider administrative costs, which we very conservatively estimated at about 10%. And what I would say at this point, just to be clear, is that we kept provider costs exactly the same. In other words, the amount of dollars that providers were being paid in the aggregate was kept the same. We didn't reduce provider payments. In fact, there were a number of task force members who felt we should have, and we could have seen even greater savings by reducing provider payments, because number of task force members felt, as we looked through the data, that by decreasing the administrative burden, that there were many providers that would see a 15–20% increase in their costs. But we didn't do that. We kept administrative savings. I think we pegged it at 8%, which was low. We kept provider rates the same. The savings really came from the provider administrative cost savings, from savings around insurance margin. There was some minimal cost savings by state purchasing power, putting together all of our purchasing power into one entity. But you have to realize we're a small state, 4 million people. I mean, we have less lives than many health plans have nationally. So putting together our purchasing power, although is a great thing, wasn't quite the savings we all anticipated. There's also some real savings in, interestingly, fraud, waste, and abuse. When you have a single payer, you can actually see where all the dollars go, as opposed to now when there's 100 payers. And the ability to sort of see where the fraud and abuse is happening in the system is something that most single payer systems are able to see and do something about in a much better way. Next slide. Yeah, sure.
I just want to reiterate something Bruce said, that we went with a very conservative estimate on the savings. Like, we could have gone a bit more, but we went to the far end, the lowest estimate, as I recall.
Yeah, and that was a strategic decision by the task force to, one, avoid a lot of providers saying you're cutting our rates. Now, some providers would see a decrease in income. We kept payments the same in the aggregate. If you saw a lot of Medicaid patients, it's likely you'll see your aggregate income increase. If you saw a lot of commercially insured patients, you'd see your aggregate income decrease. But we wanted to avoid people pointing a finger at us and saying we also had some unrealistic estimates. Next slide, there's also increased costs. This new system would cover the uninsured, everybody would be covered, there'd be better oral health benefits, most people would see a better benefit package. We eliminated all cost sharing, all of that was a cost. But when you sort of put together the puts and takes, which is what the actuaries did based on all of that data, in the end, although we saved close to $1 billion a year. Next slide. So again, this is just, obviously, there were more savings than increased payments. And, in net, we saved about 1 to 2%, but we're able to, A, cover everybody, B, eliminate the structural inequities, C, no out-of-pocket costs, no more bankruptcy, etc. No added network issues, all those things eliminated. Next slide. Oh yeah, actually I said 8%. We had costs to administer the universal health plan were calculated at 6%. There were those on the task force. Now this is to administer the plan, not provider administrative cost savings. And we chose, in this case, something to the right. We chose a high number. We chose about 6%. There are those on the task force who felt we could estimate administrative cost overhead at 2, 3, or 4%. Medicare is administered for somewhere closer to 2%. Other countries administer their plans at 2, 3, 4%. We chose 6%, again, to avoid people telling us we had unrealistic cost estimates. Next slide. We're getting to the end. Waivers. Obviously, we were putting together a single payer plan that in essence covered Medicare, Medicaid, and the commercially insured, the uninsured, all under one benefit package. We would need federal waivers to do that. We felt that we could proceed with a combination of 1115 and 1332 waivers. We also supported some congressional work that's going on to have there be super waivers for states to do exactly this. It doesn't quite exist yet. Next slide. Okay, so that's the cost. That's the plan, that's the benefit, that's the cost. Now, how do you pay for it? Where does the money come from? What we considered was basically being able to take all of the Medicare money, all of the Medicaid money that was coming to the state to fund care, and supplementing that with both a payroll and a personal income tax. We didn't come up with a final revenue plan. We ran out of time, resources, etc. And we felt that it needed a lot more work, so we didn't recommend or approve any specific tax strategy. We did come up with a couple of examples, just so you can see. Next slide. I think it's the next slide. Yeah, so a couple of scenarios. The task force looked at a scenario in which all employers paid a payroll tax on employee wages. That the example rates were 7 to 10% based on the wage, a graduated tax. When we looked at that in the aggregate, employers would contribute about 11% less towards this program than in the current system. Again, the key word here is in the aggregate. So you would see certain large employers that were currently giving a very rich benefit to their employees. They would save a lot more than the 7 to 10% that they were being taxed. They'd probably save closer to 20%. However, some small employers who were not providing any coverage would obviously see a big increase in what they would have to pay. In the aggregate, again, employers would contribute less, but there were clearly winners and losers. And the task force wanted to understand that better, and that's where we kind of ran out of runway. We also considered, well, just to put in the mix, we also considered a sales tax and then took it off the table.
Being a good Oregonian.
And someone was gonna ask about that. And we also considered an income tax. This would be on incomes over 200% of poverty. It would be graduated from 0 to 8%, depending on your income bracket. Again, in the aggregate, households would actually pay 13% less than they were currently paying. But this is where it got really complicated. So you think about this. You are a 30-year-old Nike employee. You get a great benefit package and you have a great health plan and you pay nothing towards it. And now you're going to get taxed 6, 7, 8%. The contrast to that is someone who currently is at 300% of 400% of poverty, has multiple medical conditions, has a $10,000 deductible health plan. And now they're getting taxed 4 or 5%. Actually, they're going to see probably a lot of savings from this. They won't have their $10,000 deductible. They will have a better healthcare benefit. And you know, their $5,000 deductible health plan deductible isn't 4% of their income, which now they're being taxed on. It's a lot higher. So we needed to sort of sort through all of that and just didn't have the time or the expertise to do that. Next slide. So finally, just basic takeaways. You know, our sense is that by putting together this plan, we were able to address some of the key issues plaguing our healthcare system. One, it's financial unsustainability. 2, it's harmful complexity, which we really didn't talk about, but there are people dying because they can't figure out how to get care in our system. We know that. And the fact that our current system is socially unjust. That, you know, this gets at, you know, something we're going to need to talk more about, which is, do we just put people into the current system, or do we have to radically change the current system? That savings are from simplifying the system, not from reducing provider payments, which is what people, I think, automatically, what a lot of providers automatically thought is that this is going to be about paying us less. Next slide. Federal approvals are going to be critical for any kind of a single payer plan. That we still needed a revenue plan. That taxation is really tough. As we got into that, and I think Cheryl and Warren are, this is where we had a lot of disagreement and a lot of need for a couple of things. a lot of need for, greater technical assistance from people who really understood the pros and cons of different revenue strategies. That's a whole nother sort of technical world that none of us on the task force really had to be able to understand that. And we also felt that there was a need for better ways to be able to explain some of this to the general public. And that we needed some more resource around being able to do that. I think that's it for the slides. This was a big one. And I think speaks directly to our charge, which is about, creating a plan that, given the enormity of the change that any kind of a plan would have, it, involves $50 billion in spending and the health of pretty much every single person in the state, that this was a direction to us from the task force that needs to consider designing a transition plan that builds confidence and reduces risk. I think for any of us that have been involved in organizational change that was of great magnitude and that involved a tremendous amount of risk, that you need to consider a transition plan that builds confidence and that minimizes and reduces risk. Moving from our current system to whatever we design is going to be a big change. Now I think we can go to the last slide. So the full report is actually several hundred pages. There's an executive summary. And the other piece that's on there is a really wonderful, 100+ page report from the contractor that did our outreach and consumer engagement. And just some really good and interesting takeaways in there that I'd encourage everyone to read. I think the biggest consumer takeaway that I took away from that, which was consumers are so fed up, and their concern was not to cover everybody in this broken system. That they thought it's great, you're doing all this stuff, but if it's all going to be in this current broken system that's inequitable and that discriminatory, that we're not interested. And Warren and Cheryl have their perfectly timed can add to things, and I will keep my mouth shut.
I would just like to emphasize, you brought it out a little bit. The task force elected to save in the order of 2%. We could have saved more than that, but we were recommending actually a total of 6 to 10% more services, particularly in the areas of regional, behavioral, and primary care. So I just wanted to emphasize that.
And I just wanted to 100% agree that we need significant technical assistance in the revenue part side of things. That, as Bruce said, that got really complex. Wearing my behavioral health hat, I do think we need to get clear on what's included in the behavioral health services, in particular human services too, in this plan, and what will we still be relying on, state general fund, possibly federal agency funding, like for us it's SAMHSA, for example. I'd like to know more about what's going to be included and what's not, and also provider types too. That's important for behavioral health, and I would say also in the developmental disability system as well, probably other systems. So that's one thing. And then the last thing I wanted to mention, and this is actually a question because I don't remember where we landed. I remember us talking about it a lot. But are we covering people who are working in Oregon but live elsewhere? I just don't remember where we landed, and with, so many people working remotely at this point, that's a big issue. So.
And it was a big issue, and it was really kind of surprising the amount of difference it makes.
Yeah.
Because at first, we actually, and written into 770 is we would cover people who lived out of state but worked in state. And then we was actually Chuck Sheketoff, who said, hey, aren't we violating our own standards that we're trying to separate employment from
That's right.
eligibility? And so we went back to Optimus, what would that change? And it turned out it actually made a pretty dramatic change, because the people who are driving across the bridge from Vancouver actually are healthy. And we would be actually causing a big shift between Oregon and Washington of like 3 to 4% in the cost of healthcare, because we would be taking the revenue from Washington and leaving them the populations that are currently subsidized. So that's the way we left it, is they're not covered, but we really didn't tie that up very well.
Yeah,
of exactly
That was unclear. Yeah.
how that would work, whether Oregon employers without state employees, whether they would just purchase insurance in the Washington market, say for instance.
There's no workforce.
It's actually more detailed than once you drill into it. There's a lot of small pieces.
Yeah.
So I'll point out, we have a couple more minutes for conversation and questions about this. But all of this work, including the transition plan and what we do with the task force recommendations, that's going to be the focus of our planning work group, which we'll talk about as our last agenda item. This is what that group will be doing, is taking these recommendations from the task force, working through, what is it that we need first? What is it we need second? Like, how do we implement a plan based on these recommendations? So this is just our first in touch on this task force report. Obviously, this is the foundation of our work. If we have a couple more questions now, we can take them, and then we're going to break soon and come back to the rest of our agenda. Go ahead, Amy.
One question is, and this might be something for answering later, but the PED benefit that was used as the kind of underlying assumptions, in general, is that benefit, or what Oregon Health Plan members get as a benefit, which one's like more generous, I guess, or more, covers more?
They're different.
Yeah.
I would say the Oregon Health Plan benefit is more robust than the PET benefit. The Oregon Health Plan benefit has, well, by definition, no copay, co-insurance, etc. It covers more services, long-term care and other services. This gets into some of the details around the plan. Our analysis, however, assumed that if you were a Medicaid eligible, that you would continue to be able to get the Medicaid benefit. Was the minimum Medicaid benefit, because it was our assumption that the federal government wouldn't give us a waiver to use Medicaid dollars unless we continue to provide the minimal Medicaid benefit. So it gets, and particularly around the long-term care issue, I mean, long-term care is 30–40% of our Medicaid expenditure. And some of those, that's where a transition plan is gonna need to be thought through. I mean, there's a lot of issues like that where we just didn't have the time.
And then,
Boiling it down,
yeah,
I think the idea was nobody loses anything.
yeah.
Some people get more than they have.
Exactly.
And then, since when all of this analysis was done was prior to COVID, I assume, just things like people working remotely is grossly different, but healthcare, like,
Yeah,
if we did that analysis today, I assume it would be,
it would, but the basic analysis was just trending,
yeah.
you know, taking the same period of time,
Mhm.
whether it be pre-COVID or post-COVID, and, you know, trending current versus, you know, new system.
Mhm. I mean,
But I think there'll be some things, you're right, like remote workforce,
and
be really different.
potentially more disabled folks from long COVID and
Yeah.
some other things, that might be, higher use.
Yeah,
less
it'd be
employment
interesting
tax.
which way that
Yeah,
spins it.
I had two quick questions. The part of Devlin's presentation that I always find really shocking is the amount of care that's avoided because of costs by people. And how, when in the cost estimates, how much was that included? Did you, because that would be dramatic if people could get all the care that
It was assumed, it
they
was,
would get all the needed care.
yeah. Pent up, the actual analysis included, you know, pent up demand.
Yeah.
Et cetera, yes.
Okay, good.
And what people were not getting now because it was too expensive.
Okay, great. And my second question is on workforce. Did you tackle that at all? Because building this is going to require really steep investments in primary care. We only have like 30% primary care providers, and we need closer to like 50% of providers in primary care to accommodate that kind of access. Was that addressed at all?
No,
Okay.
the short answer, no, other than a recognition
Yeah.
that, we would need a workforce. It was interesting, I mean, a lot of discussions, particularly with, providers and different advocates on different sides of the issue, who felt that, a plan like this, that providers would flee the state and, because they would perhaps lose revenue. And others of us who felt that actually, providers were likely to come to Oregon because it would allow them to work in a system that was more just and where they were able to do what they went to, professional school to do. We had a lot of conversation about that. Judy's got a question.
Go ahead, Judy.
Thank you. And this follows on Helen's question, and I recognize it may be more a question for the transition plan, but was there any discussion or work in the task force about how to help patients or manage folks who are now receiving care at the ever increasingly vertically integrated delivery systems that include embedded insurance? For example, providers who work for an integrated system that is also an insurance company, and the patients get their care there. It may be a disentanglement kind of question of the transition group, but I was just curious if there was any discussion about that.
No, I think it was. That was subsumed in, there's a lot of transition issues to think about. That's why. That's why we exist. And I think that as we got to the end of our work, quite frankly, the number of transition issues began to logarithmically increase. No, and hence that last recommendation of, you know, it's one thing to put together a plan. It's another thing to really deal with many of the transition issues of going from current to future health system.
Okay, Michelle, and then we're gonna need to take a break.
Thank you. I was just curious if in the cost savings analysis, were facility fees accounted for? Were they allowed, not allowed, accounted for, not accounted for?
You mean in terms of, you go in for surgery and outpatient surgery and you pay a facility fee and a doctor fee? That type of fee?
But I'm even seeing it at primary care clinics. You pay your, insurance covers the encounter, but then you get billed separately a facility fee.
Yeah, it did, it included all those facility fees.
Okay, thank you. And we will definitely pick up this discussion in the work group. It's 11:05 right now. We can take a 10-minute break and reconvene at 11:15.
It was actually, you know, if you remember, I was doing one of these every week.
Right, we are unmuted.
Okay, great. Welcome back. At our first board meeting, Dr. Chenwei Chi spoke briefly about the need for an ethical framework for universal healthcare. And as we launch into this work, it's important that we have a discussion and at least some agreement on the principles that underlie our work. Of course, some principles have already been put forth in both Oregon's constitutional amendment on the right to healthcare and in the text of Senate Bill 1089, which established this board. And these principles we're taking as a given. We already committed to those. And the exact text of both of those are in your meeting materials. But we've asked Dr. Chi to talk today about his broader work on the development of an ethical framework for universal healthcare systems, with the idea that there may be additional principles we want to consider in our work. After his presentation, we can have a discussion about that and possibly establish a work group if we feel like that's worth exploring further. So at this point, I'll hand it over to Dr. Chi.
Yes, thank you very much. I will be very brief because the whole issue is way more complicated. And in our April meeting, I mentioned one of the shortcomings of Taiwan's universal health plan was when it was established, unlike the SB 1089 has laid out much more clearer ethical principles in which Taiwan did not. And the major drawback of that has been, now it has been implemented nearly 30 years. And every time when facing potential new technology or emerging disease, new drugs, there is no systematic way to determine which one will be covered. And the result it ended up being the maneuvering of political power. And the group that has bigger voice usually gets heard and they get priority. And so we should avoid that situations. Please move to the next slide. So as Morgan already mentioned, in the SB 1089, it already laid out quite a few values and principles. And in this page, I specifically highlighted some of the language that we will need to develop some more detail and operationalize it. So for example, in the Article 23A Part A on the equitable basis, but equitable basis can be derived from many possible foundations. On the Articles 23A Part B, towards the bottom, it says may not create barriers to health care nor result in disparities in health outcomes due to the lack of access to care. This one is particularly complex and also require our group to develop how to operationalize it, but it also needs some ethical principles and distributive justice. And then in Article 23B Part C, regarding the participant in the plan together with the provider should make decision about what is medically necessary. And again, this need to be operationalized. And lastly, I highlighted the Article 23B Part D. The plan shall cover healthcare services and goods from birth to death based on evidence-informed decisions as determined by the board. And no country with universal health care could cover everything that's available or everything that's effective, because every country, and Oregon will face the same constraint, will face the financial constraints. And how do we determine what are the most necessary, most essential? We need to develop some basic ground rule, and that basic ground rule require some ethic principles. Next, please. Next slide, yes. So this next slide highlighted why a universal health plan needs an ethical foundation. And there are 4 components in, I highlighted 3 of the components in red, and the one coverage we can ignore because the SB 1089 already clearly stated about who shall be covered. So, but in terms of the governance, we are still facing who will make key decisions such as taxations, fundings, the overall coverages, and as well as the process of decision making. And on top of that, who shall decide or choose what will be the ethical foundation and distributive justice for our planned universal health plan? And on the component of finance, the task force and also Bruce's report already detailed. It will be tax financed, which kind of tax is waiting to be decided, to be developed. But the ethical foundation requires us to decide what would be the equity principle of the financial burden. Particularly earlier, I mentioned about what are the current financial burden by income group, whether it's by income quintile or deciles. Likewise, what should be the equity principle of the payment system? And then on the last one, priority. Oregon was the world's pioneer between 1989 to 1992 to apply a very explicit method to prioritize condition treatment pair for the Oregon Health Plan. And more importantly, prior to Oregon's pioneer work, the academic world and policy world studying or deciding healthcare priority treated priority setting as a pure scientific or engineering endeavor. But Oregon's experience showed the world, the academic world and policy world, no, the priority setting is not a technical scientific endeavor. It's a political endeavor because priority setting is all about value, about preferences. And so here I highlighted 3 examples what we may need to deal with and that require ethical principle, especially distributive justice. Number 1, what services should be covered? And this has been important questions that the academic world has done research for decades, try to decide what should be the essential healthcare. And of course, what are essential will be vary by context, particularly by country, by regions. And number 2, whose health conditions should be covered? Because when we are considering what health services should be covered, we should simultaneously consider which population group suffer from those conditions. And sometimes it may not be just the cost effectiveness of the treatment that matters. Sometimes it also matters that when we decide a particular condition to be covered and another condition will not be covered, we were inadvertently excluding a group of people's their health condition are being ignored. And then lastly, whether and when to cover new technologies. We continue to face the development of new technologies, including pharmaceuticals. And this will be a continuous challenge for us when we to review, to evaluate which new technology, which new drug, which new treatment we should cover. And without an explicit systematic distributive justice principles, this will be ended up being in a political maneuver, like Taiwan experienced now. The group with bigger voices, they often get what they want. Next slide, please. So in terms of distributive justice, there are multiple schools of thought. And I just highlighted some of the more popular. The libertarianism, which is also integrated with individualism that emphasize individual liberties. And then the utilitarianism that emphasize the collective well-being, but generally ignore the distribution effect. The Rawlsian is unique in the sense it's try to emphasize the people at the bottom's benefit. And then the last one is rather popular among the public health professional, the communitarian ethics that emphasize we think about the policy, the system as a social institution, and we think members of the society as a one entity, not as individuals. And simultaneously, the communitarian ethic also emphasize the equity issue in terms of taking care of people at the bottom. Next slide, please. And in operationalizing distributive justice and equity, let's say we, through certain process, the board decided on a particular distributive justice, but to operationalize it in the universal health plan in terms of what service should be covered, who should be covered. And we still face a more detailed choice of focus space of equity. And in universal health plan, the equity we are concerned is about health. But health can be defined and measured in so many different ways. And depending on the focal space we choose, it will have a profound impact on the actual policy implementation. Next slide, please. And in one of the article I sent to Morgan, that's now in the open access, was an empirical study I did with one of my former PhD students using Chile. Chile also has a national healthcare system. And we did that study mainly as a kind of both experiential but also empirical, because that study follow it's a sequel to the previous study we conducted. Through a national survey, we asked Chilean people what are the most important healthcare issues they concern within their healthcare system. And through that previous survey, we identified the top six healthcare issues. And so in this particular public value preference survey, we did the two part of the survey. One is to ask them of the 6 top priority they identified. If we have a limited budget, what would you prefer the national health care to prioritize? Which of those 6 should receive high priority? And we did not ask them in vacuum, because we give them a symbolic token representing budget and ask them to allocate those symbolic budget to the 6 different priorities. And they can allocate all of them in one priority or distribute differentially across 6. And then in addition, in parallel, we were testing whether it is feasible to investigate public value and preferences in terms of distributive justice for health care. So in this last slide, I highlighted 4 most popular, but these are not an exhaustive list of distributive justice in terms of equity in health and healthcare. These are the 4 probably the most popular ones. So they are equal access for healthcare and equal access for equal needs, and then equal access for equal ability to benefit from healthcare. And last one is equality in health. And each of this, depending on which principle a system choose, again, will have a profound impact on deciding what healthcare services and whose healthcare service will be covered. And based on the SB 1089 stated the value and principles, we probably will have to identify something more complicated than a single distributive justice principles. And that is a task that we need to identify. And my last comment is, who should choose or identify distributive justice principle for this universal health system? My suggestion is we should find a method to obtain the Oregonians' public values. And there are already different methods available that we can explore. And of course, the board can decide which entity or through what method, what institution should make that decision. And finally, I like to quote my important mentors that have profound influence on my thinking and my idea of health systems. The late Professor Will Reinhardt. And he said, Americans typically shy away from an explicit statement on social ethics in debating health reform. Instead, that debate is couched mainly in terms of technical parameters. However, any management discussion of health system, health economic is fundamentally an ethical question. Thank you.
Thank you, Dr. Chi. Does anyone have any questions? Go ahead, Shel.
This is really a process question. So what do we do with this? I mean, how do we, as Dr. G said, how do we determine or identify these, the distributive justice principles? Is that something that our board will do, or not clear on that?
Yeah, I mean, that's for us to decide, right? So we have, you know, the Oregon constitutional amendment in your meeting minutes, which outlines, you know, what was put into our constitution on this topic. Thank you. My right glasses on. And in here, it talks about that every resident has a right to cost-effective, clinically appropriate, and affordable healthcare as a fundamental right. And it's the obligation of the state to balance that right with other public goods and needs. And then, as Dr. Chi put in his presentation, 1089 outlines some principles. And the question before this board now is, are those sufficient in order for us to build a plan and to do our work? Do we feel that it's clear enough in this one and in the second one? Is there another slide on the 1089 ones after this? Yeah, here's the 1089 ones, that healthcare is a fundamental element of a just society, that we have to make sure that the system doesn't create barriers to health based on any characteristic of a person, nor result in disparities. The system has to be accountable and fully transparent, and that it's that it has to be operated by a public trust. Is this oh, that's right. And then the Part B principles, that choice of provider is an important principle, that the plan may not discriminate against licensed healthcare providers providing services in the scope, that medical necessity should be able to be determined by the participant and their clinician, and that services from birth to death based on evidence-informed decisions. That's what we have right now. We have those are established. Is that enough, or based on what we've heard from Dr. Chi or other, you know, information that you have, do we need to think more about what else should be involved? The paper that's in our meeting materials about ethical priority setting talks about, you know, 3 sort of universally agreed on principles among international circles, that it should promote health maximization, that there should be a fair distribution of resources, and that there should be protection against poverty. Those, when international groups talk about universal healthcare, those are the 3 that seem to have broad agreement and acceptance. And there are dozens more that, you know, are that some people support and others don't. And so that's for us to decide now, is that, should we include any, do we feel like what we have so far encompasses these 3 major principles? Should there be other principles addressing cost? Should there be an additional principle that gets further at the quality of care, or how that care is distributed? Should there be a principle around, you know, how healthcare is delivered in terms of, you know, do local communities have more controls? You know, how to, it's up to us to discuss that. And if this group feels that we do need more than what we currently have, then that's what we would establish a work group to figure out.
I feel a work group coming on.
Go ahead, Amy.
I definitely think that we need a work group and to dig further into this. One of the things that I saw on the slide referenced was QALY, which we now have ending quality.
So can you explain what that acronym is?
Quality adjusted life years, which Disability Rights Oregon has been fighting to end maybe since it started, but at least for like
Forever.
20 years.
Mhm.
So I think, yeah, I think this is an area where we need a work group and we need to be informed more by, you know, those are most impacted. And I don't know what this means in terms of a principle, but something about not sacrificing the most vulnerable, which, you know, doesn't, it's not a pretty way to say that, but
Okay, great. Yeah, so far 2 calls for a work group. Anybody else have questions on, you know, principles that we should be considering or thoughts on that, or opinions about a work group? Go ahead. Warren.
I'm just going to add that, I mean, there's different levels of the values and principles that we need to be working on. Some of them are very basic, and I really appreciate Dr. G's presentation on this is very good, but there are then kind of secondary levels of what do we do about the role of the employer? How do we engage communities so that we're getting inclusive and equal participation by a lot of stakeholders? I mean, there's lots of things that happen at the sub level to this that I think that we need to reach some understanding. In some cases, maybe not full agreement, but understanding early on that we can use to build our later work on. So I am very much in favor of the formation of a work group on this.
Bruce?
Yeah, first off, Chenwei, that was great. I really love the way you laid that out. And I hope that as we move forward with put together principles that you're a part of that, because we really need your expertise. I think we need to have a set of principles that we just keep measuring our work against. And that just makes a lot of sense to me, and we should, I mean, we could spend 2 years doing that, but I think we should spend, you know, a month or 2 and get it done and move forward. I'd really be in favor of a work group to do that.
Cheryl?
I agree, and this, we may be getting to this by that principle of promoting health maximization or by addressing quality of care, number 4. But I want to make sure that we focus on health outcomes too. I mean, providers, a lot of times are counting widgets, you know, they're doing X, Y, Z, A, B, C, but I'd really like to focus on health outcomes.
Okay, great. So it seems like there's pretty broad support for the creation of a work group to formulate some recommendations to this board on the principles we should use as we move forward in our work. And I think we can have one motion that establishes the group and its members. So can I ask who would be interested in joining that work group? We have Amy Fellows, Warren George, Chun-Wei Chi, and Michelle Glass. Anyone else? No limit, how much? No, yeah, that was Lee. Deborah Diaz, jump in. Deborah Diaz also, great. Great, anyone else? Good, okay, so I think we need a motion to establish a work group focused on making recommendations for principles that includes those members. Should I name them again, or?
Amy, Warren, Chenwei, Michelle, and Debbie.
Amy, Warren, Michelle, Chenwei, and Debbie.
Any objection if I add to principles measures, call it principles of measures, because I think you really do need to measure, and Chenwei kind of brought that up. Are we looking at, as Cheryl did too, are we looking at life turning, long life expectancy? Are we looking at patient satisfaction. I mean, there's a lot of different measures. I will withdraw that if I don't see any support, but anyway, I think that will become an additional topic.
Okay, yeah, that can be an additional topic of the group. Okay, so do we have a motion to create that group with those members
So
in a second?
Second.
Any discussion about it?
It would just have it be time limited.
Time limited.
And
Yeah.
we don't have to include that in the motion, but my suggestion would be not to, this can get
Right.
out of hand in terms of time. And it's really important, but I just think we need to be able to get it done and move on.
you have a suggestion, 3 meetings or
I-
I would just leave it up to the group with that.
Perhaps the suggestion could be like an initial draft of principles by the June meeting and try to get them finalized by the July meeting. Chenwei? Yeah, go ahead, Chenwei.
Yes, I was thinking about the same idea. To identify the ethical principle, especially distributive justice principle, how we apply that to the detail. For example, maximizing the population health, but whose health are we maximizing given the limited resources? We really need some guideline. So my suggestion is for this work group, we develop preliminary guidelines. And knowing that before we finalize our proposed plan by 2026, there will be room for improvement or revisions. But we need some guideline to start to work with. And I fully agree with Bruce's idea that we should be aimed at proposing some idea in the next meeting and finalize it in July meeting.
That'd be great.
That'd be awesome. Yes, excellent. Great. So we've had a motion and a second. Any other discussion? Yes, go ahead.
For Dr. Chi, I first want to thank the papers that you shared with us. Some of them left me kind of like a cliffhanger. I wanted more. And just given your expertise, if there's any additional resources that could help this work group and myself, who is not an expert in this area, I would greatly appreciate that.
Yes, I will share more resources, particularly one of the paper by I co-author with my former PhD student Rebecca Shim, who is actually participating as a public here. We use citizens jury that has become a very popular method to derive consensus from the population. And that would be a method I highly recommend we consider if the board decided we want to solicit the Oregonians' thinking, idea, values. And I will provide some references on the citizens jury.
Great. Okay, so we're ready for a roll call vote on this measure. It's been proposed and seconded.
Yes. Helen Belanca,
Yes.
Chenwei Chi,
Yes.
Deborah Diaz,
Yes.
Amy Fellows.
Yes.
Warren George.
Yes.
Michelle Glass,
Yes.
Chris Goldberg,
Yes.
Judy Richardson,
Yes.
Carol Ramirez.
Yes.
Excellent. Okay, we have one more agenda item and then we do have some public testimony. So I'll turn it over to Morgan for an update on our work plan development.
Sure, thank you. So there are a couple of slides to walk through, but I will go straight to the punchline. This is a request for another work group to work on developing a work plan. And I think in conversations with the chair and the vice chair staff and OHA staff who worked on the task force, the Senate Bill 1089 really has some strategies for how to do our work, but it does have a lot of areas for feedback. And so wanting to get a work group working on that work plan so that we can adopt it very quickly. We have in a very aggressive timeline of just under 2.5 years. So you'll see really to focus the next couple of meetings on the grounding, foundational work, hearing from the Bruce on the task force recommendations, identify some of these committees and work groups, help us figure out what consultants we need for this first couple months. And the consultants will be for figuring it out now, but for our work into the next year or two. And really have our work group working while the board is hearing those foundational topics, and come up with a good work plan. And just to highlight a couple of the deliverables that we have coming up, this first report to the legislature by December 1 is going to come quicker than we realize. So we need a work plan to help us do the work. So now, next slide. So we've already kind of talked about at the last meeting where we'll focus our time and effort for the June, July, and August meetings, that grounding foundational work, talk about community engagement, hear updates on how from other states, do some learning about the Employee Retirement Income Security Act, ERISA. We heard a little bit about how the task force addressed that in their strategies, but so the board will know a little bit more about what that means as we move forward. And then we'll want to approve that work plan no later than August. And if we are ready to approve it in July, that may be something you want to strive for to make sure we have that work plan. Next slide. So the work plan will help develop the plan for the 2.5 years, and make recommendations to the board at the July meeting. And then we can give updates at June and July, and if needed, have August, but really strive for that July timeline. And then also, because of the need for a financing committee to get going on the work, one of the tasks we're asking that work group to do is to develop some thoughts and recommendations to the board about who would serve on a finance committee. Who are their participants? Is it just board, outside experts needed? Work on the scope of work and the timeline for that finance committee so that we really can get that part of the work going as soon as possible.
Right, so the work group ask is for a planning work group that over the next 2 to 3 months is going to outline overall our general plan, look at the task force recommendations, kind of come up with what we need to do when, and then that group will probably morph into topic specific groups. Definitely a finance type group, probably an operations group, and of course a community engagement group. So being part of this initial planning group means you kind of just want to get in there and start thinking about our work plan and all of the work that is needed. And then it'll be divvied up over time. So I encourage anybody that's interested in this planning work group to jump in so that we can start digging into what we need to accomplish in the next few months. Are you have a question or volunteering?
Volunteer.
Okay. Okay, great. So yes, so Warren, George would like to volunteer, Debbie Diaz volunteering, Cheryl.
I have I'll volunteer with a contingency
Okay.
that we have to have it done in 2 months.
Yes.
And that's that if we're gonna have our first meeting, that we have a draft work plan from staff to look. I'm not interested in a part of creating something
Yes.
from. We need to have something for 2 years that we can react to.
Okay. Yes, so, yes. Okay, so have with the draft, yes.
And
Okay.
Michelle. Michelle, raise your hand.
Okay, and Michelle, you're volunteering or have a question? Volunteering? Okay, great, and I'll volunteer. Yes. Anyone else? Amy? Yay. Is that everybody?
Practically.
Chenwei did not. And Judy did not, right? Okay, good. Okay, great. So I need a motion to create a planning work group consisting of board members, Amy, Debbie, Helen, Warren, Bruce, Cheryl, and Michelle. Is that accurate? Did I get one? Okay, do I have a motion for that?
So move.
Cheryl, and a second?
Go ahead.
Okay. Bruce moved and Cheryl seconded. Any discussion? Okay, and roll call vote, please.
Helen Blanca,
Yes.
Chenwei Chi,
Yes.
Debbie Diaz. Yes. Amy Fellows.
Yes.
Warren George.
Yes.
Michelle Glass.
Yes.
Chris Goldberg.
Yes.
Judy Richardson.
Yes.
Carol Ramirez.
Yes.
Excellent. Michelle, you still have your hand up. Did you want to say something or was that for participating?
Yeah, I had raised my hand for discussion, but just to make a comment to the 40 or so folks who are on the call, that I think that I'm really excited about this planning work group for the developing the work plan. And that I think this is going to be the beginning of developing that public engagement strategy so that we can coordinate with you all and all of the folks who are interested who aren't on the call. And I really appreciate you being here and engaged and your patience with us as we develop that strategy to engage in a way that, centers community voice from the beginning. And just to reiterate that my clear intention and the reason I joined this board was to do that engagement work, and that this isn't something we're going to develop a whole plan and then roll it out to you all, that we're really looking forward to that meaningful engagement from the beginning, and that this is the beginning of that work. So thank you for being here, and I'm really looking forward to getting that plan developed and to digging into that really important work with Oregonians.
Thank you, Michelle. Thank you for saying that. And yes, I'm in full agreement with that sentiment, and apologies for not recognizing you during the discussion part of that vote. But yes, I really appreciate you chiming in with that.
Michelle, could you introduce your guest?
And my apologies, my two cats, Fred and George Weasley, are my coworkers and frequent guests on all Zoom meetings. And so you will be seeing them for the duration of my term.
Okay, any other thoughts on business, or we'll move to, oh, yes, Amy, go ahead.
So for the two work groups that we just formed, will staff be wrangling us and kind of putting something out, like doodle or something to see when we can?
Yes, so you'll be getting an email from Katie, our executive assistant, and she will confer with you about meeting times, and those will be entirely virtual, I'm guessing.
Yes.
To make it easier for everyone. So yes, so you'll hear from Katie, look for those emails and respond quickly so we can get them rolling, please. Anything else? Yes, we do. So we do have some public comment. I believe Richard, I apologize, I can't read your last name. Richard Walsh, yes, come on up.
Hello, members of the governance board, and thank you very much for letting me have a few minutes here. My name is Richard Walsh.
Will you hit the button? Yeah, the light. Perfect.
Perfect. Hello, my name is Richard Walsh. Thank you very much for letting me have a few moments. I wanted to introduce myself. I'm an attorney here in the Salem Kaiser area. I do personal injury work. I have represented over the last 35 years thousands of injured workers that have had to deal with our healthcare system. I've dealt with the tragedies and the people being uninsured, and the tragedies of people being insured but being restricted and being tied to their jobs, and all the stuff you guys are dealing with. I also have been a public official on the Kaiser City Council, and I've also been, I recently ran for Senate for District 11, and in doing so, I walked this area, thousands of doors, and I talked to literally hundreds of people about universal health care, because that was one of my big issues. And I just wanted to share with you what I think I've learned after talking to hundreds of people individually at their doorsteps about universal health care. And I think it's simpler than people are making it out. There's two big issues that I found out over and over. One is that when it comes to what the plan is going to be, they just want a plan that's the same or better than the plan they have. So, and everyone thinks that state workers have the best plan. So if you had a plan that you could advertise as good as state workers get, you're gonna get all those people on board that have insurance. That's the big issue. Are you gonna have a plan? You don't need to cover everything. You don't need to have zero deductibles. You don't need to make it the greatest plan in the world. All those things are really, really expensive. You don't need to do that. You just have to be better than the plan they have for most people. And that, I think if you got a state plan. And then how do they get protected, that they won't take things away? You make sure that legislators get stuck with that plan. But that's the plan they get. And if they want to change something, they're changing it for themselves and their families. And when I tell people that, they're like, oh, they're gonna greatest plan in the world. So there's a lot of confidence in that. So I think it's simpler that way. You don't need to even do the one from the task force. As great as it is, if you just tell them it's as good as the current plans, that you're good. Second thing is, everyone wants to know how much they're gonna cost. And that's the other big issue. And that big issue is also simple. It's, will it save money for them? Now, I know we all talked about, we're gonna save $1 billion, we're gonna save millions of dollars, we don't have advertising, we don't have corporate taxes, we don't have, CEOs being paid, blah, blah, blah. That doesn't mean anything. It matters, is it cheaper for them? And the math is gonna be, are they gonna get, a savings because they've saved the premiums, or because their boss saved premiums and passed that on to them? And I think that, I was talking to you about that a little bit. If there's a way that you can pass the savings, because all the savings are gonna be by employers. I'm an employer, I have 10 employees. I'm gonna love universal health care. I'm gonna save thousands of dollars. Don't make it that easy. Why should I save the money and then the bill gets stuck on the taxpayers? Give me an incentive to give a raise to my employees in the amount of, let's say, 80% of the savings that I made from premiums. I know this is complicated and legal and all that stuff, but that's what energy should go into. So that when the employee goes, oh, I'm gonna get a raise of $1,000 a month. What is the average premium now? $1,200 for a family, $1,500. So I'm gonna get a raise of $1,000 a month. Sure, I could pay a tax that'll cost me $200 a month or $300 or $400 a month. Then it becomes very sellable. So it's who's saving the money. And if you can answer those two questions, then you've got a winner. That was something that'll pass, I think, the legislature and will pass the voters. If you don't do those two things, it's not gonna work. Like I said, I talked to too many people. That's all that matters. And so, yes, you can do a lot of things to get more money into the system with the federal government. Of course, you gotta work on that, get the Medicare money, the Medicaid money, maybe veterans money, maybe you can get other systems pulled in, all these different child care programs, all these different piles of money. I think I counted like 30 or 40 different healthcare related things where we spend money on, little Band-Aids here and there. If you could gather all that up, state and federal, then you'll have a big pile of money, and then the tax will be whatever's left over, and then you just have to make sure people save money. Once you have those budget numbers, then you go, oh, what's the best we can do with what we got? And not try to say, let's do the best program and how much is it gonna cost, but how much do we have to work with and do the best we can with what we got while we got it. And anyway, I just encourage you to kind of follow that approach. I think it'll work. Any questions?
Thank you.
Just a comment, I really appreciate the simplicity of message, and I think that we were talking about this at the break, that it's really important to be able to talk about this in simple terms that people can understand and not get into a very complex discussion about any aspect of this, but to really boil it down to its essence. So really appreciate that.
Thank you. Oh, and are the workshop meetings also gonna be noticed?
Yes.
Yes.
Thank you. Appreciate you coming. Anything else we're missing?
Well, just to say out loud, or louder, the two work groups that were just formed will be public meetings. A bulletin will go out to the folks signed up on our listserv. And meetings will be available for the public to listen into. That's what we're learning about the new public meeting laws for the board to come together and talk, that we have to notice them as a public meeting.
I meant there'll be the opportunity for those to be virtual.
They will definitely all be real. Yes, yes.
I would recommend that they only be virtual for those ones.
I'm good with that.
Yeah. Any other last thoughts? Great. I want to thank Katie DeLuca so much for your support for this meeting. It went out without a hitch. So thank you for all your work. Thank you to the staff, Jenny and Morgan too, for helping this meeting. And thank you all for coming and attending. Appreciate it. Thank you. Oh, right. We have a quote. Thank you. So we're trying to adjourn with a quote or a saying or a story. And the one that I brought today is one from